So renal mass biopsy is a little bit of a controversial topic. So I can't claim to be an expert on this topic, and my opinion is gospel, and not at all. There's plenty of room for discussion, criticism, debate on this topic, but I'm just going to give you my take on this, just a more practical approach to renal mass biopsy. And then you can take it or leave it, it's up to you. I would certainly say, though, that within the last few years, there's been a lot of talk about renal mass biopsy, a lot of people who have been really championing it, trying to push for it, telling us that we should be biopsying all these tumors. So to a degree that I think it's kind of like a fad that, people were saying that renal mass biopsy, new standard of care, renal mass biopsy, just do it in Journal of Urology. And then you have some people like Jamie Landman and Stuart Wolf. You've got several of these, big name guys, very smart guys, much smarter than me, certainly, who have really been telling us that we should biopsy a lot of these tumors. In fact, this is a quote from Jamie Landman, who I have a lot of respect for. And his suggestion was that in the US, only 6% of patients are getting renal mass biopsy, but probably 94% should get renal mass biopsy. So is that really true? Do 94% of patients with a renal mass need a biopsy of their tumor? I'm going to argue no. But again, there's plenty of room for discussion and debate. So let's talk about what are we trying to achieve with a renal mass biopsy. So let's start and say, okay, what would be the perfect ideal? If we had a perfect renal mass biopsy, what would it provide for us? Well, number one, it would tell us whether it's cancer or benign. It would tell us whether it's aggressive cancer or a more indolent cancer, which is really your grade. It would have minimal or no complications, and it would be low cost and easy to do. If all of these things were true, then we would probably say, yeah, we probably should do biopsies in the majority of patients. So let's look and see if that's true. So I'm going to show you a couple large studies. This was one that was published in April of 16 in European Urology. It was a meta-analysis of 57 papers with a total of 5,000 plus patients who had renal mass biopsy. Now, only 7 of these 57 studies specifically looked at small renal masses, which means that there were majority of the series were including 10 centimeter tumors, 13 centimeter tumors, 18 centimeter tumors, 20, 32 centimeter. Why would you biopsy a 32 centimeter renal mass? Well, people are doing it. And so a lot of these patients were those. What you need to keep in mind, though, is that the smaller the tumor, the less diagnostic the biopsy. So if you have a 30 centimeter mass, then yeah, you're probably going to have a diagnostic biopsy. But the smaller the tumor, the less your differentiation. So according to this paper, the sensitivity of a biopsy for a smaller renal mass is lower. So if it's a 4 to 6 centimeter renal mass, your sensitivity is only 84% versus 97% for all comers. Well, really, the small renal mass is the one that we care about. We don't need a biopsy for a 15 centimeter tumor. So if the small renal mass, it's going to be less diagnostic, then obviously we can't go off of these papers that are telling us the sensitivity of renal mass biopsy is 94%. Well, yeah, but that's not really true. Those aren't the ones we're actually going to biopsy. So the smaller the biopsy, the less diagnostic, but those are the ones that we care about. So that's the take-home message from that paper. Well, here's another one. So this one was from May of 16. This was a meta-analysis of 20 studies of almost 3,000 patients who had a renal mass biopsy. But 11 of these studies included tumors that were less than 5 centimeters, that were T1A, and then 3 of them were less than 5 centimeters. So there were 6 studies, in other words, that were including larger tumors. So the same problem with the other papers, that they're still biopsying some big tumors that we really probably wouldn't biopsy. But at least 14 of the papers in these 20 were for T1A or less than 5 centimeter tumors, which are the ones we care about again. So how likely were they to differentiate cancer from benign? So again, our ideal biopsy is going to tell us, is it cancer or not? It's got to tell us that at least. 14% of these were non-diagnostic, which I'm sure if you've sent patients for renal mass biopsy, you've seen this over and over again, non-diagnostic. 4% were false positive, meaning that it told them that it was cancer, but it turned out it was benign when they took it out. The negative predictive value in this meta-analysis, the negative predictive value was 63.3%, which means that over a third of patients that the biopsy said were benign actually turned out to be cancer if they had the tumor removed. So can you imagine that a third of the time the biopsy tells you it's benign, but it's actually cancer? That makes me nervous. I don't like that. So is the biopsy really as sensitive as people are telling us? Also, we said that the ideal biopsy would differentiate between high grade and low grade, because if we're considering doing surveillance on somebody, we want to know, is it high grade or low grade, right? Well, in only 2/3 of the cases was a grade even given. So many times the pathologist will say, well, we can't grade it. We don't have enough tissue, or we just can't tell. So many times they won't even give you a grade, low grade, high grade. 1, 2, 3, 4. In 16% of cases, it was upgraded, so they said it was low grade. It turned out to be high grade. Concordance studies, so people have looked at concordance of grade on biopsy versus grade on final pathology. If you look at it, there's a wide range, but it goes somewhere between 50 and 75%, which means that it could be as often as 1 in 2, that it tells you it's low grade, but it's really high, or it tells you it's high, but it's really low. So it's a crapshoot, in other words. So is the biopsy telling us what we need to know to make treatment decisions? How confident are you in your biopsy? So essentially, the grade on the biopsy is pretty useless, is what I'm saying. So if it tells you it's low grade, you can't trust it. If it tells you it's high grade, you can't trust it. So again, from this meta-analysis, looking at even including large tumors, the grade concordance was 62.5% if you use 4-tier, meaning grade 1, 2, 3, 4. If you use just high grade, low grade, it's much better, it's 87%, but still, are you going to be able to make treatment decisions on those patients if that's your concordance? And again, for small renal masses, your ability to diagnose it as cancer or not, and your ability to give a grade is going to be harder for a small renal mass. It was only 2/3 of the time that there was grade concordance if it was a small renal mass. So how confident, again, are you to take this to the bank and make a treatment decision? Are you going to trust it? And then we said the ideal biopsy would have low or no complications. These are the complications rates, again, in these 2,000 or so biopsies. Hematoma rates about 5%. Significant pain, meaning that they needed to be admitted to the hospital for pain, 1.2%. Hematuria, 1%. Pneumothorax, I mean, that's a pretty awful complication. Significant hemorrhage, and then on rare occasions you have things like AVM or tumor seeding, but honestly, these are so rare that we really shouldn't use them to argue against biopsy. So if somebody tells you, well, I don't do renal mass biopsies because of tumor seeding, I would say, yeah, that's not a good argument. It's really, really rare. But one of the arguments I would make is that for those of us who are doing robotic partial nephrectomies, how does the complication rate of the biopsy compare with the complication rate of robotic partial nephrectomy? My own personal experience, my transfusion rate is less than 1%, so the bleed rate is the same or better than renal mass biopsy. Urine leak rate is well below 1%. Again, I've not had any patients who've had AVM, pseudoaneurysm, or bleeding to need to go to IR. Most of these are an overnight stay. And the complication rate, including medical complications, is about 5%. So it's very similar to a biopsy. So why not just cut it out? And then what about cost? So again, the argument is by many people, they say, well, do the biopsy because it might save you from spending the money on the partial nephrectomy. If it's a benign tumor, you don't have to take it out, you saved a lot of money. Okay, let's analyze that and see if it's true. How much does a renal mass biopsy cost? So in this paper in Journal of Endourology, they compared the cost of renal mass biopsy by IR versus doing it in the office. If IR does the biopsy, it's $4,500. So if it's CT or ultrasound guided by IR, it's $4,500, which is a lot. If you do it in the office, they could do it for $2,100, which is obviously a lot cheaper, but they didn't count the complications. They were just looking at the cost of the biopsy. So if there was a complication, the patient had to be admitted or transfused or whatever, they didn't count that. So we're just talking about the cost of the actual biopsy. So the cost is certainly much less in the office, but in the office, you're going to only be doing the easier tumors. So even somebody who's an expert at this, Jamie Landman, whose paper this is, even somebody like him who's an expert at doing office-based renal mass biopsies, they're still cherry-picking the tumors. They're doing the less complex, the more exophytic posterior tumors. Even with these cherry-picked tumors, still 21% were non-diagnostic. So that means 1 in 5 biopsies that Jamie did in the office didn't give a diagnosis. It was a waste. So again, we said these are the ideal characteristics that we would want in renal mass biopsy, but are we getting this out of renal mass biopsy as we do it today? But the main problem, again, from a practical point of view, the main problem that I would tell you with renal mass biopsy is that rarely do I find that it changes my management. And that's the biggest argument why not to do a renal mass biopsy, is very rarely does it change your management because the pre-test probability of cancer is high. Most renal masses are cancer, we know that. Grading is poor on the biopsy anyway, so it's not going to help me decide because I'm not going to trust the grade. And in most cases, the treatment decision is pretty obvious without a biopsy, and I'll show you some examples of that in a minute. So ultimately, what I would say is that we should only do procedures that are diagnostic if they're going to change our management. So don't do a CT or an MRI or a renal scan or whatever genomic testing for prostate cancer. Don't do these things unless it's going to change your management one way or the other. Don't just do it because you want to. So there are certain cases where I would say just don't do a biopsy. For example, this large renal mass that's in the cava, don't do a biopsy. It's not going to change your management. It's ridiculous to do a biopsy in that case. Don't do a biopsy if you're already planning surveillance on that patient. So if I have an 80-year-old patient with a 1 centimeter renal mass, and this patient, there's no way she could tolerate surgery anyway, why would I biopsy that tumor? If anything, it's going to make her nervous because it's going to come back cancer, and now she's going to say, well, what do you mean you're going to do surveillance? I have cancer. I'm better off not doing a biopsy in that patient, telling her, look, it's most likely cancer. It may not be, but we're just going to watch it. Don't do a biopsy if you wouldn't trust a negative biopsy, or if you're planning to intervene anyway, meaning that if the risk of a false negative is too high, then don't biopsy it, just take it out. So for example, if I have a 40-year-old patient, very healthy, long life expectancy, and I said to myself, okay, so there's maybe a 20% chance that this thing is gonna say benign, but it's cancer. Am I gonna trust it? No, not in this patient. She's 40 years old. I'm taking it out. Then why get a biopsy? So I'm gonna show you my real world experience and make an argument against renal mass biopsy. So this is a series over the course of 3 years. I did 161 robotic partial nephrectomies, of which 87% were malignant. Now this is higher than what you'll find in the literature for small renal masses in particular. But the reason why is because I do active surveillance. So if you do active surveillance, then a higher proportion of the patients you operate on are going to be cancers. So 87% in my hands are cancer. So I do active surveillance, but I almost never biopsy. I'd say less than 10% of the time I biopsy. So we're going to look at the cost in this population of patients if we did 94% of patients a biopsy like Jamie recommended. So this is the real world. Welcome to the real world population, everyone but you. It's just funny what you can find on Google. All right, so 161 renal masses, and this is a busy slide, but I'm going to walk you through it. And I'll kind of, if anything is confusing, let me know. So if 161 renal masses, based on the meta-analysis, the papers that I showed you, reliable papers, European Urology, Journal of Urology, 15% of your patients are going to be non-diagnostic, which is 24. So 24 of my 161, if I biopsied all of these patients, 24 would be non-diagnostic. So I might send them for a rebiopsy because I really, really want to know. Well, on rebiopsy, actually, the success rate's 83% according to the literature. So I would still have 4 non-diagnostic. Now I did 2 biopsies, still have 4 people non-diagnostic. 17 of these would be cancer based on the pretest probability, because again, in my hands, 87% end up being cancer. So 17 of these have cancer, they're still having surgery anyway. 3 of these would say benign, but because of the negative predictive value of 68%, 1 out of every 3 is going to really be a cancer. So they're going to keep growing their cancers. I might do another biopsy down the road. Oh, actually, it turned out to be cancer, or it's growing too fast. It's still a cancer. We're still going to do a partial. So that guy's going to eventually, maybe a couple years down the road, is going to end up over here. All right, let's look at the rest. 137 of the 161 are going to be diagnostic. If they're cancer, so again, 87% are going to be cancers, so these people are going to go to partial nephrectomy. 18 are going to be benign. And you would say, oh wait, now I don't have to do surgery on these 18 people. I just saved 18 people from surgery out of these 161. But one of those is a false positive. And so they're going to have a surgery anyway. So one of them is going to end up being a cancer, and they're going to go to have a partial. And then you're going to have, again, these false negatives because of the negative predictive value of 68%. 6 of these are still going to be cancerous and eventually are going to have surgery. So of these 18 patients, and of the other 17, there were 6 that actually had cancer, but the biopsy said benign. I'm going to want to take those out anyway. So how many patients did I actually save? Well, we did 185 biopsies because some we had to do more than once for being non-diagnostic. We still ended up treating 148 out of 161. So we avoided 13 surgeries, but we did 185 biopsies to achieve that. So what's the cost? If we send them to IR, which I do, I don't do biopsies in the office. So if I send them to IR for the biopsy, I'm spending $4,500 a piece. So that's $832,000, But again, if I said 94% of patients need biopsy, not 100%, then I can cut that down to $782,550. What that translates into is $60,000 per avoided robotic partial nephrectomy. So for every patient that I saved from a partial nephrectomy, I spent $60,000. What's the cost of a robotic partial nephrectomy? It's about $10,000 to $12,000. So I'm actually spending 5 to 6 times the amount of money to avoid that surgery compared to doing a partial, and then, hey, guess what? It turned out to be benign. Your complication rate was 1%. Patient's happy, doesn't have to have surveillance scans. So I think this fad is changing. I think this push to tell us that we need to be biopsying everybody, I think this pressure is now starting to abate because the recommendations are now backing us up. So this was a nice paper that came out in European Urology. It was a nice kind of consensus statement from some big-time experts in kidney cancer who are giving us this flow chart for when we should do a renal mass biopsy. And this really makes great sense. It's telling us that if lymphoma, abscess, or metastasis is suspected, then do a biopsy. But how often does that happen? Extremely rare. Is the patient an active surveillance candidate? Yes. Is there a clinical benefit to histologic risk assessment? In most cases, no. In most cases, when the patient's a candidate for surveillance, you don't need a biopsy to tell you that. You can just put them on surveillance without a biopsy. So still, most of these patients are not going to get a biopsy. Is ablation planned? Well, if it is, then you're going to do a biopsy at the time of ablation, but again, that's the minority of patients. And is the patient treatment team willing to observe benign lesions? If the answer is yes, then do a biopsy. This also includes being willing to accept the false negative rate. So again, if the biopsy tells you benign, you have to be willing to accept that it might be wrong and that it could be a cancer. If you're willing to accept that, then do the biopsy and follow those patients. If you're not willing to accept that risk, again, 40-year-old patient, for example, then just take it out. In most of these cases, though, the answer is going to be no, 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 no. So the vast majority of patients are going to be no biopsy. And fortunately, the AUA came out with guidelines on this last year. You can go and look at this. All of the AUA guidelines are online at auanet.org. And this is what they're recommending now is renal mass biopsy should be considered when a mass is suspected to be hematologic, metastatic, inflammatory, or infectious. Again, that's rare. Renal mass biopsy is not required for young, healthy patients who are unwilling to accept the uncertainties associated with the renal mass biopsy. So again, 40-year-old patient with a renal mass, I'm not willing to take a 1 in 3 false negative rate. Older, frail patients who will be managed conservatively independent of renal mass biopsy. Patients that you're not going to operate on anyway, even if the biopsy says cancer, don't do a biopsy, just put them on surveillance. And then counsel regarding rationale, positive, negative predictive values, potential risks and non-diagnostic rates of renal mass biopsy, and then multiple cores are preferred over FNA. FNA is useless. If your radiologist want to do an FNA on a renal mass, don't even bother, it's not going to tell you anything. Which also counts for cystic lesions. So cystic lesions, the diagnostic rate on a cystic renal mass, a complex cyst, is terrible. So I don't even bother, I don't even consider it on a cystic renal mass. So I mentioned before that if you're going to put a patient on surveillance, you don't need a renal mass biopsy for that. Why? Because when you put them on surveillance, we know from the natural history of untreated renal masses on surveillance what their growth kinetics are. And typically the growth kinetics of a renal mass are going to be less than 3 millimeters a year. If it's less than 3 millimeters a year, you can pretty much take it to the bank that that is something that you're not going to have to operate on. So this was one paper that was published in the Gold Journal in 2016, where they looked at a group of patients that they just followed and then eventually ended up doing surgery on them. So they took those tumors out and could tell if they were cancerous or not. What they found was about 60% were grade 1 to 2, 40% were grade 3 to 4, so it's a pretty representative sample. And they found again that about 3 millimeters a year was the median growth rate. 3 millimeters a year is kind of a reasonable cutoff. It was low grade 75% of the time. If it grew less than 3 millimeters, if it grew more than 3 millimeters a year, then the odds ratio was almost 4 times that it was grade 3 or 4. All right, so that's the argument against renal mass biopsy. Now I'm going to share with you some real-world cases. So these are examples from my own personal practice. These are not like, cherry-picked from, the internet or something. These are literally my own patients. So this is a 45-year-old male with a 5-centimeter right upper pole mass. Before he was sent to me, he was sent to IR for a biopsy. I would say, why? He's 45, he's got a 5-centimeter mass. Why are you biopsying this? I'm doing a partial. But guess what happened? Afterwards, he ended up getting a urine leak from the biopsy. Isn't that a tragedy? He didn't need a biopsy in the first place. He got a urine leak from the biopsy. Here's a 72-year-old woman with a 3.2 centimeter renal mass. She comes with the biopsy. The biopsy says papillary RCC, so now she wants a partial. Now, honestly, if she had come to me without a biopsy, I probably could have convinced her to do surveillance. But now she's coming to me with a biopsy, and it's cancer. I've got to have this out, doctor. I said, all right, we'll take it out. What did we find at the time of surgery? This is the picture of the ultrasound, intraoperative ultrasound. Can anybody tell me what we're looking at? This is a complication of biopsy that will drive you crazy. This is the tumor right here, and this is all perinephric hematoma. It was a disaster. I've had several of these. One of my referring urologists literally biopsies every single renal mass. And their IR guys, I don't know why, but every so often they create these huge hematomas for me to have to dig through to try to do the partial. So that was just a video showing how ugly it was, but we'll skip it. All right, here's a 45-year-old with a 2-centimeter renal mass. Does this patient need a biopsy? Well, the primary care physician thought so because the radiologist recommended a biopsy in his CT scan. So the CT scan report said 2-centimeter renal mass, recommend biopsy. So the primary care doctor didn't know better, sent the guy for a biopsy. What did the biopsy say? Benign renal cortex, no neoplasm identified. Anybody else had one of these? Benign kidney on biopsy? Yeah, because there's a non-diagnostic rate. They're not going to hit it every time. So we still did a partial on him. I said, look, I don't need another biopsy. I'm not going to send this guy for a second biopsy. I'm going to do a partial on him. He's 45, 2-centimeter renal mass. We took it out. It was cancer. We didn't need the biopsy. Here's a 33-year-old with a 2-centimeter renal mass. Somebody sent her for a biopsy. Biopsy said renal cell carcinoma, but unable to determine subtype. Did we need a biopsy on this patient? 33-year-old with a 2-centimeter renal mass. I'm going to take it out either way. I'm not willing to accept a 1 in 3 chance that the biopsy would say benign, but it really ends up being cancer. 45-year-old with a 6-centimeter renal mass, also sent for a biopsy. Why? I don't know. I'm going to take it out. Biopsy said oncocytic neoplasm consistent with oncocytoma versus chromophobe RCC. Absolutely useless. Anyone else has had this before? All the time, right? Chromophobe versus oncocytoma. They can't tell you. Useless. 79-year-old with 2 renal masses. In this case, again, 79 years old, 2 small renal masses. I would just do surveillance. In fact, I would avoid a biopsy in this patient because I want them to be less nervous, not more nervous. What did the biopsy say? Oncocytoma versus chromophobe versus clear cell versus papillary RCC. Absolutely useless. These are real-world cases, patients sent to me. Here's a 72-year-old with a 1.7 centimeter renal mass. The urologist referred him to me, did a biopsy, but it was non-diagnostic. They weren't able to get enough tissue to make a diagnosis. So he comes to see me, and I said, you know what? You don't need another biopsy, but you also don't need surgery. You're 72, you've got this little tumor, we're just gonna watch you. What ended up happening on surveillance? The tumor got smaller. There's the tumor before, 6 months later, I said, go away, you don't need anything. So avoided a biopsy. Here's a 5-centimeter complex cystic mass in a 78-year-old. This person had not 1, but 2 non-diagnostic biopsies. Why? Why? This doesn't need a biopsy. We just put him on surveillance. 6 months later, it hadn't changed. The guy's going to be on surveillance for the rest of his life. Doesn't need a biopsy. Here's an 84-year-old with a 4-centimeter renal mass. The referring urologist sent it for a biopsy. And the result was oncocytic renal neoplasm. The findings could represent an oncocytoma, although certain types of renal cell carcinoma with oncocytic features, i.e. chromophobe carcinoma, cannot be excluded. So again, how did this biopsy help me? I could have made the treatment decision based on this. 84-year-old, look, we're gonna do surveillance. We're just gonna watch it. Don't worry, don't do a biopsy. So again, if you're planning to do active surveillance on somebody, you don't need a biopsy. You just do growth kinetics and you follow them with scans. So that's my argument against renal mass biopsy. Again, it's not dogma. It's not set in stone. It's open to criticism, debate, alternative opinions. Again, there are very smart people, much smarter than me, who feel the opposite on this. But this is just my own personal recommendation, my own personal opinion. Reminder again about the NARIS meeting in Las Vegas. I'm going to keep reminding you because I want to see you guys there, and also for the people online who are joining us throughout the day. And I'll stop there. Any questions? Everybody agrees? I convinced you all? That was easy. Man, you guys are easy. All right, thanks, guys.